Good morning, everyone. It's a pleasure to introduce you Dr. Lee, the fourth-year resident with us, and he will talk about complications following inguinal hernia repair.
Thank you, Stefan, for your kind introduction. Welcome, everyone, to today's presentation about complications following inguinal hernia repair. So, why is this topic important? Inguinal hernia repair is one of the most common procedures performed in general surgery. In Switzerland, around 17,000 hernia repairs are performed each year. During the last few decades, there has been a huge advancement in the surgical techniques. In the past, the anterior suture repair used to be the standard, such as the Schuldi's repair. However, in the 90s, there's a new change. The tension-free mesh repair was introduced. Along with this, the Liechtenstein procedure was created, and later on, through the introduction of laparoscopy, also posterior approaches such as the total extraperitoneal repair or the transabdominal preperitoneal repair are created. Through the advancement and the shift from suture repair to tension-free repair, there has been also a change in the complication. So what are the most common complications? It's the hernia recurrence, it's the development of chronic pain, and the development of seroma. In the past, hernia recurrence used to be a big complication. However, after the tension-free mesh repair was introduced, the incidence of recurrence has been reduced significantly. So today, during the presentation, I'd like to elaborate on each of those complications, explain what the risk factors are, how we can prevent them, and how to treat them. So let's start with hernia recurrence. It is a very distressing experience for the patient having undergone a surgery, but later on still suffering under a similar condition. And it can cause some doubt whether the surgery was performed correctly. Here it's important to distinguish between early recurrence and late recurrence. Early recurrence can be due to technical errors and occur usually between 3 or 6 months after the surgery, whereas the late recurrence appears later. It can even last a couple of years after the surgery has been performed. And those are mostly due to patient factors, which are smoking, diabetes, obesity, old age, or patients who got a recurrent hernia repaired. Those factors all are responsible for bad wound healing. So what are the technical errors? For example, when the hernia was repaired under tension, when a hernia is missed during the surgery, when the mesh size is inadequate, or when the mesh is not properly fixated. For open approach, the most common recurrent hernia is the direct hernia, and it is often due to insufficient fixation of the mesh in the medial side. And for the laparoscopic approach, it is commonly the indirect hernia due to a missed cord lipoma. Here we have a patient who received uncomplicated hernia repair through a TAP method. However, after the surgery, he still has symptoms and discomfort in the groin region. When the surgery was done again, we can see that the mesh is properly placed and there is no sign of a hernia. However, when exploration was done, we can see that there's a lipoma which has been missed during the primary hernia repair. And through the reduction of the lipoma, the patient was happy again. So we all know the critical view of safety from laparoscopic cholecystectomy. Here, Dr. Days and Felix coined the term critical view of myopectineal orifice, which is this region. And it consists of 9 critical steps, which should be followed before the mesh is placed. It starts with identifying the pubic tubercle as a starting point and also as a landmark. The dissection is continued above the Cooper ligament to rule out any direct hernia. Then a space is created between the Cooper ligament and the bladder, where the inferior border of the mesh will be placed later on. Dissection is continued between the Cooper ligament and the iliac vein to rule out any femoral hernia. If there is an indirect hernia, if there's any indirect hernia, the hernia sac is reduced and should be dissected away from the spermatic cord. Any tension should be reduced so that in the end, the spermatic cord lies flat and there's no tension. Furthermore, we should pay attention there's no cord lipoma to prevent pseudo recurrence. Dissection is continued to the lateral and inferior side for proper mesh placement later on. The upper border is an imaginary line between the anterior superior iliac spine, and the mesh should be placed above this line. And finally, when the space is deflated, we should pay attention that the mesh doesn't roll up to prevent mesh displacement. By following those 9 steps, it is very unlikely that a hernia is missed, and it guarantees that the mesh is placed properly. So how do we treat recurrent hernia? In general, we treat symptomatic patients, and we do a tension-free mesh repair. Here the principle is to leave the previous mesh intact and avoid the same surgical plane due to scar tissue. So for example, when the primary hernia was repaired with the anterior method, we should do a posterior method or vice versa. We need to keep in mind that the complication rate increases after each recurrence. As we can see here, the postoperative complication increases after each recurrence. The recurrence rate is also higher after each recurrence because after each surgery, the tissue gets weaker. And also patients develop more chronic pain after the surgery. So now we arrive at the second topic, chronic pain, which is a very cumbersome issue for the patient. It is defined as a pain impacting daily activities for longer than 3 to 6 months. What are the risk factors? At risk are young female patients, patients with already a preoperative pain syndrome, patients who develop severe postoperative pain, or patients who got a recurrent hernia repair or postoperative complications. We need to keep those risk factors in mind so that we can identify those patients at risk early on and prevent chronification of pain. So we can distinguish chronic pain into neuropathic and non-neuropathic pain. Neuropathic pain is caused by direct injury to the nerve, such as when the nerve is transected incidentally during a surgery, or when the nerve is entrapped by a suture or mesh. Patients usually complain about a sharp stabbing pain, which can be located by a trigger point. The Tinel sign is positive, and the pain is distributed in a certain sensory distribution. Non-neuropathic pain is caused by local inflammation, which can be caused by recurrent hernia, mesh infection, or seroma. And here patients describe the pain to be dull and constant, and there's no specific trigger point. So for the diagnostics, it's very important first to get a good history, to understand the characteristics of the pain, and also to do imaging to rule out the causes responsible for non-neuropathic pain. Now let's focus on the neuropathic pain. So which nerves are in danger during surgeries? For the open approach, there are 3 nerves. First, the iliohypogastric nerve, which supplies the region in the inguinal region and the pubic region. Then there's the ilioinguinal nerve, which supplies the medial thigh region. And there's the genital branch of the genitofemoral nerve, which supplies also the thigh region. For the genital branch, it is the scrotum or the labia. Yeah. The nerve mostly in danger is the iliohypogastric nerve, as you can see here. Because this nerve is very exposed, it often interferes with mesh placement, whereas the other two nerves are less in danger. So how can we prevent an injury to the nerve? Here, the first point is very important to identify the nerves. And second, to do pragmatic resection. What does pragmatic resection mean? It doesn't mean that we need to cut away all the nerves we see, but those at risk. So for example, when it interferes with the mesh, for example, as you can see here. Some other measures can be taken by, for example, not to make the external inguinal region too tight so that the ilioinguinal nerve is impinged. Also, we need to pay attention not to place sutures too deeply because sometimes nerve can run below the internal oblique muscle and can be entrapped. For the laparoscopic approach, it is the femoral nerve of the genitofemoral nerve, which is in danger, and also the lateral femoral cutaneous nerve. Here it's important to pay attention to the triangle of pain and not to place sutures too deeply in this region. So chronic pain is a complex topic and it requires multidisciplinary approach. So the general approach is to start with a conservative treatment with pain medication. If that doesn't help, we often do a local nerve block. It is on one side a diagnostic tool, but also a therapeutic tool. And it helps us to identify the specific nerve which is injured. It also helps us later on for the neurectomy to know where and which nerve to resect. Neurectomy can be done openly or laparoscopically. There's no much difference. However, there's a recommendation for triple neurectomy instead of selective neurectomy because the success rate is higher. Triple neurectomy means we take out all the three nerves. However, the downside is the patient have more numbness after surgery. So now I'd like to show you some intraoperative pictures where neurectomy was performed successfully and patient got a relief of pain. So here, for example, we see a neuroma, which was caused by a nerve injury during the surgery. Here we see the entrapment of the ilioinguinal nerve by a suture, which was later resected. And also here we see a meshoma, which means that the mesh infiltrated into the nerve and the whole thing with the mesh was resected. So when the neurectomy is not helpful, the next step would be to use neuromodulation. It is based on the gaze control theory, which states that constant stimulation of the sensory nerve will inhibit the conduction of pain signals. Since all the three nerves originate from the L1 and L2 root, spinal root, we can place a neuromodulation catheter into the dorsal root of L1 and L2. And through constant stimulation, patients actually feel more paresthesia in the region where they felt pain before. And there's actually a small study which shows that patients benefit from this procedure. However, it is still an experimental procedure because the case numbers is very low. So now I'd like to move on to the last topic, which is about seromas and hematomas. Here, patients at risk are those with coagulopathy or those who take anticoagulants. those with cardiac insufficiency or liver cirrhosis, and those with a large inguinal scrotal hernia due to the large dead space. A technical way to prevent seroma is, for example, to obliterate the potential dead space by reducing the hernia sac. So one can reverse the transversalis fascia and tack it to the pubic symphysis, or one can use a loop to suture it up. And this procedure has been shown to reduce the risk from 14% to 4%. Another debated measure is the placement of surgical drain. Here we have a meta-analysis which clearly favors the placement of surgical drain. However, that's not the question. We don't want to know if it prevents the formation of seroma, but we are more interested in the clinical significance. And here in another study, we can see that actually a very low percentage of those patients with seroma needs clinical treatment. And there is no difference whether you place the drain or not. The complication rate for intervention and infection is about the same. So the recommendation is not to place surgical drain routinely for uncomplicated hernia repairs. However, for patients with with many risk factors and who received a complicated surgery, of course, you can place a drain here. So to finish up, I'd like to present the patient. We have an 81-year-old patient with right groin protrusion. And here a CT was performed. Can someone comment on this CT? Yes, please.
I think it shows an inguinal scrotal hernia.
Very good. So let's see it again. On the right side. Here, very good. So the patient underwent Liechtenstein procedure. However, 2 weeks after the surgery, he came back to the clinics and complains about a recurrent groin mass. And here again, a CT was done. Can someone say what they see here? Yes, please.
Looks like a fluid collection.
Very good, yes. We have a fluid collection. It can be seroma or hematoma. So the question here is, should we puncture it or not?
I think we should only puncture if it's bothering to the patient.
Very good. So the question is whether the patient is symptomatic or not. Here, Dr. Morale actually proposed a seroma classification for type 1 and type 2 seroma, which lasts less than 6 months. They are considered as incident, not as complication, because those seromas actually resolve spontaneously and doesn't need therapy. However, for patients with symptoms, or for those with seromas lasting longer than 6 months, we need to do something here. For type 3 seromas, we can puncture the seroma to reduce the discomfort. And for type 4 seromas with maybe deep infections, mesh ejections, or hernia recurrence, those patients need surgery again. So I'd like to finish up with some take-home messages. For the recurrence, we should follow the critical steps of myopectineal orifice and pay attention how we place the mesh. We should avoid, when treating recurrent hernia, that we don't use the same surgical approach. And we need to keep in mind that complication rate increases after each recurrence. For chronic pain, it is important intraoperatively to identify and resect the nerves at risk. We should distinguish between neuropathic and non-neuropathic pain. And for those patients with chronic pain, we need to provide the multidisciplinary care in a specialized center. And for seromas, we can reduce the incidence with the reduction and obliteration of the hernia sac, and we should only treat symptomatic seromas. Thank you very much.
Well, thank you very much. Excellent presentation. I learned a lot. Maybe one short question. We speak about hernia repair using mesh, which has been a switch over the last maybe 20 years. So maybe my question to Dr. Gerdes is there still an indication today, that's the way I think I train, for Schuldeis or the Schuldeis-like fascioplastic repair done, for example, in local anesthesia. In my training, several years ago, that was what we were doing. It was in Basel, patients were coming, do local anesthesia, same-day surgery, Schuldeis, and home. Clearly, there is wrong indication for that. Is this still good indication?
So actually we do it anymore here. We only do mesh repair, and we can also do mesh repairs in local anesthesia. So that's no problem. Also for patients with high morbidity, we can do it in local anesthesia. But the Schuldeis technique is, if you do in the literature, if you do it in a clinic which only do a Schuldeis repair, they had the same recurrence rate. But if you do it usually, I think the recurrence rate is much higher.
What is the Schuldeis clinic in Toronto? But of course, I think the conversation is the selection of patients, right? I think if you take patient high risk, whatever the quality of the surgery, the recurrence rate is high. But if you do selective in a really low risk patient, that's where they were not accused, but I mean that was explaining the very good result of doing that, and I think they are still doing that in selective patient with good success. So.
Thank you very much. Very nice presentation. I have a question to dissecting the nerve. Just technically, how do you dissect the nerves with cautery, ligation? How do you dissect?
Coagulated very laterally, and then we dissect it. So there is a discussion if you do have to a suture, a ligation, but I think it makes more neuroma, and so we only coagulate it and dissect it.
Thank you.
Thanks also from my side. Very nice presentation. May I ask, what's the value of the hernia med registry in following complications and recurrences after hernia repair? Are we part of it? And as far as I'm aware, it would allow to measure complications like % or even per individual surgeons. Is that right?
So there's a good study. You have to have a long follow-up to get all the recurrence rates. So there are exactly here. You have to look over 5 to 6 years to get all the recurrence in it to see them. There are also recurrence which come after 10 years. Yeah, and we put our data in a registry, but not in this you mentioned. Yeah.
Beautiful presentation. Thank you very much. My question relates to the different types of surgeries. You've presented the complications very nicely, but my question really would be: we have a variety of surgical techniques. We have open anterior, we have minimally invasive, TEP, TOP, we have robotic. How do these different procedures compare with respect to the incidence of chronic pain and seroma formation? Is there any technique that does superiorly to the others?
Mm-hmm. Yeah, there's good studies. We have to see that the chronic pain is more in open techniques like Liechtenstein. If you do an endoscopic repair like a TEP, you have less chronic pain events in these patients. There's a good study about it. You have to see them. This is significant. And the seroma, it depends really on the morbidities and the risk factors of the patients. So the patients we see here in our presentation, it was a repair after Liechtenstein. He was quite old, had cardiac morbidities, and so he got this seroma, but he was asymptomatic, and after a few weeks, it was fully resorbable from the body.
Any benefit for the robot with respect to these complications?
Actually, it's not well described, but if you see it, it's quite the same like a TEP or a TAP from the outcome from the chronic pain. Yeah.
Thank you.
Thank you for the very nice presentation. I have a question regarding the table when and how to treat the seromas. Regarding the table, you showed us basically that you would only treat the seroma and puncture if it's older than 6 months. Is that right? So within the first to 6 months, you would try to treat it conservatively, right?
That's the only study we found about it. So we do it we make it from the symptomatic of the patients. So we look how is the patient symptomatic, and then we treat this seroma. And otherwise we control it. Seroma over 6 months is really unusual, and perhaps then you have to look what's the fact behind it. Perhaps you have to reopen it and perhaps to clean it with surgery. Yeah.
Okay.